So let's see what's happening in Italy. Pain and swelling, analgesic, usually paracetamol. If insufficient, we use ketoprofen. Opioid, we use only the first day if needed in the hospital. Localized, normally cryotherapy if game ready is feasible, and compression and extended limb elevation to minimize the swelling. Then the immediate post-operative care, standard ACL reconstruction is no bracing for sure, early mobilization day 1, progressive bearing for the first 15 days with crutches, no prophylaxis with low heparin, and the indication can change depending on meniscal and cartilage treatment, so we use the brace only if we use some of this type of treatment. So this is what I'm doing. Simple meniscal lesion, no bracing, weight bearing, partial weight bearing for the first 15 days, mobilization active and passive after the 30 days, flexion limitation, no, heparin, no. Complex meniscal lesion like root lesion, I normally use bracing for 15 days, no weight bearing for 15 days, then active and passive with CPM after 5 days, and avoid flexion after below 90 degrees for 3 weeks. The cartilage treatment, yes, bracing, depends on lesion localization, condyle or trochlea. We use brace or not, and the weight bearing is normally at 3 weeks, I normally give weight bearing. Active and passive with CPM after 7 days, flexion limitation, no, and heparin, yes. So muscle strength, as obviously early strengthening of quadricep with isometric contraction starting from day 1, stretching of posterior chain muscles, early mobilization and activity to decrease limb swelling and immobilization. So with what strategy to increase range of motion? We use Siglet with progressive saddle lowering, hydrokinetic activities after the 4 weeks, rest with support under heel, full extension, knee flexion under gravity, sitting on high bed table, and you should trust your ACL reconstruction, and early movement is the key for us. And how you educate? You should talk with the patient and physio to give them educational material, enhance compliance and motivation to increase early functional recovery and return to sport, limit kinesiophobia to decrease the time to return to sport, encourage monthly follow-up visit, and monitor clinical status in steps in order to have no delay in work on drive unless a surgical complication. So make the patient feel healthy again. So this is important, and you should have also psychological support to this patient. So we are lucky to be in Bologna with isokinetic, and this is the surgeon, sport doctor, and physio is synergic, is the key to success, and rehab in step with progressive tests to evaluate progress, and is not a time, but is a step-wise rehab. And so in conclusion, I would say the early mobilization is key to early postoperative full range of motion and muscle trophism recovery. Evaluate bracing and heparin case by case. Risk of hematoma and stiffness is harder recovery, and you have really risk of complication. Meniscal and cartilage lesions are guiding your patient early recovery, and you should not underestimate this. Visit your patient periodically, make a better rehab, not only a fast rehab. And artificial intelligence and strict collaboration between surgeon and physio could lead to further improvement of ACL outcome. Thank you.